Hey everyone, welcome to Everything Optometry. Picture this, a patient comes in for a completely routine eye exam. They're seeing perfectly well, they have absolutely no visual complaints, but when you look inside their eye, the retinal blood vessels are telling a completely different, much more alarming story. You see, the retina is literally the only place in the human body where we can directly observe blood vessels, and sometimes it reveals dangerous systemic diseases before the patient even knows anything is wrong.
In this explainer, our agenda covers taking the clinical history, mild to moderate signs, severe acute retinopathy, the clinical examination, and finally, referral decisions. Let's get right into it.
So here is the big question. If a patient with high blood pressure walked into your clinic tomorrow, would you know exactly what retinal signs to look for and when to refer them urgently? It's a scenario every single pre-reg and qualified optometrist faces. By the end of this, you'll know exactly how to make that call.
Okay, Section 1. Taking the clinical history.
Before you even pick up your ophthalmoscope, you have to ask these foundational questions. Note their primary reason for the visit, like were they referred for a second opinion? If they do have symptoms, ask if the onset was sudden or gradual. Verify their medical history regarding high blood pressure, and here is a massive exam tip. Always check their medication compliance. Are they actually taking their meds? But there's another crucial set of questions you really can't afford to skip.
This right here is a classic trap. You must ask about these secondary neurological symptoms, even if the patient swears they are completely asymptomatic. Why? Because a patient might not connect a recent dizzy spell, a weird headache, or a bit of limb numbness with their eyes. They just don't make that connection. But you have to, because these specific symptoms point straight to severe acute hypertensive retinopathy. You literally have to fish for them.
Moving on to Section 2, mild to moderate signs. In mild to moderate cases, patients are usually completely asymptomatic. Think of your patient's blood vessels like a garden hose. Imagine turning up the water pressure in that hose and leaving it like that for years. Eventually, the walls become damaged, narrowed, and totally stiff. The exact same thing happens inside those tiny retinal arteries. You'll start to see a broadening of the arteriolar light reflex and narrowing arterioles. Normally, the AV ratio, that's the thickness of the artery compared to the vein, is around 2 to 3. But as those arterioles clamp down from the high pressure, that ratio drops significantly.
Now, pattern recognition is your best friend here. Look closely at how the vessels cross over each other. This is arteriovenous nipping, or AV nicking, and it's one of the most famous signs in hypertensive retinopathy. Imagine a heavy, stiff metal pipe pressing down hard on a softer rubber pipe underneath it. That's exactly what the thickened, hardened arterial wall is doing to the underlying vein because they share the same adventitial sheath.
You need to draw a hard line in your mind for your exams and your practice. Mild to moderate patients feel totally fine. They rarely have visual problems. But severe acute patients, they are experiencing active, alarming symptoms. We're talking blurred vision and severe headaches.
Which brings us to Section 3, severe acute retinopathy, the clinical emergency. When you look at the progression side by side, the escalation is honestly striking. We go from the subtle AV nicking of mild disease to a visually chaotic, highly symptomatic disaster zone. We've crossed the line from a few stiff vessels to a complete catastrophic breakdown of the retinal blood barrier.
Just look at how much is going on when severe acute retinopathy hits. You've got blot hemorrhages everywhere, hard exudates pooling up from vascular leakage, extreme arteriolar narrowing, and worst of all, massive disc edema.
Let's break down these hallmarks. Hard exudates are lipid deposits from leaking vessels. Then you have cotton wool spots. These are essentially the retina's desperate cry for oxygen due to ischemia. You'll also see phlegm hemorrhages, which by the way are totally distinct from the dot blot hemorrhages you'd see in a diabetic patient. And the absolute biggest red flag, bilateral optic disc swelling. If you see that, you are looking at malignant hypertension. That is a sight-threatening and potentially life-threatening emergency.
Section 4, the clinical examination. Let's systematize this.
If you segment your internal examination, you won't miss these critical clues. First, check the retinal vessels specifically for that AV nicking and narrowing. Next, sweep the general fundus looking for the diffuse signs like cotton wool spots. Finally, hone right in on the macula to check for exudates and hemorrhages right at the center of their vision.
But your most important target zone is the optic disc. Any elevation or hyperemia, obscured blood vessels, venous congestion, fine hemorrhages right next to the disc, or fuzzy, indistinct margins, those are massive red flags for optic disc swelling, pointing straight to severe acute disease.
And finally, Section 5, Referral Decisions. This is the most important part of the explainer. Think of your referral decisions as a clinical traffic light system. A red light means severe acute signs with bilateral disc swelling. That is an absolute same-day emergency referral. A yellow light is for an untreated mild to moderate case. This gets a routine, non-urgent referral to their GP to finally get their blood pressure sorted out. And a green light? That's for an asymptomatic patient who has mild signs but is already being actively treated for their hypertension. They just need standard monitoring.
The critical distinction to remember here is life oversight. We send those bilateral disc swelling patients out as same-day emergencies because we urgently need to rule out raised intracranial pressure. Routine referrals are simply to help the GP manage the patient's long-term, untreated chronic high blood pressure before it gets worse.
Okay, listen closely, because students get this wrong all the time and it causes unnecessary panic. If your patient is asymptomatic, they only have mild to moderate retinal signs, and they tell you they are already taking their medication and being actively monitored for high blood pressure, you do not need to refer them. There's no action to take other than noting the findings and monitoring them routinely.
Before we wrap up, let's do a rapid-fire clinical quiz in your head. Case 1, you see mild narrowing. What grade is it? Case 2, you spot AV nicking. Case 3, cotton wool spots and flame hemorrhages pop up. Do they need a routine or an urgent referral? What if it's case 4 with full-blown disc swelling? I really hope this explainer has sharpened your clinical instincts so you are completely ready to make the right call in practice. Keep looking closely. Thanks for joining me on Everything Optometry, and I'll catch you in the next one.